Yes. Okay.
And yeah, I think it was mainly infection.
The
I don't think
HBR
it was
is
dominant
that
to
one.
But it wasn't the same surgery.
Oh, it was just
Well, no, well, we did one Sunday was the starting point. And then she got an infection and then the code, you know, to the
It's working
and
very well.
then they take her home and she was sent along to us.
Yeah, that's terrible.
So she had no.
I don't know exactly what they've done for the ingrown toenail. I'm not sure. It was almost like it just got bigger and bigger. It was, you know, a series of direct things. I think there was at least 3 procedures that happened, you know, whatever it was started it off and then something was done to try and take a bit more off and then into a mess. She was beside herself and, you know, she was a complete nervous wreck. We had to sedate her fairly heavily with Connex until we can get her in the chamber.
One often gets more to the other.
No, I don't think so. I mean, I think the main role of the negative pressure therapy is when you've got an open wound and you're trying to bring the edges together, or when you're trying to keep a graft opposed to the base. I think they've done a fantastic marketing job, and I see it being used in a lot of situations where I'm really sceptical that it's going to work. You can't pull blood out of a stone, is my analogy. But the idea of hyperbaric is we're soaking the oxygen onto the plasma, so there's much more oxygen delivered to the tissues from the inside. So you can blow oxygen on the outside, but it doesn't work because it's back to front. So we're putting the oxygen from the inside, so you've got more substrate there, and then if you can suck and help to bring the wounds bases together and so on, I think they should be complementary.
Next question, do you do the debridement as well? When you have clients in, say, for 5 weeks or whatever it is?
I mean, I'll do doctor in the clinic type debridement, but
it's not.
I don't do surgery taken into theatre anaesthetized and sterile field. So
similar to what Foss would do, just similar to what we would do with.
I would say so. Yeah, if it's sharp debridement. I've also got a Sonica. I tend to use the Sonica more on leg ulcer type wounds and. My only caution with some of the debridement is in some of the really ischemic people, I've seen situations where they don't respond very well to the debridement. A couple of really ischemic people where you've got to be very cautious about at all, and sometimes the yellowy, blacky thingy that's sort of stable and not can be left a bit longer. I mean, hyperbaric will help things to demarcate. There are some times where it just needs a lot longer.
So I'm just going through.
And so when you stop at the 50 or whatever it is sessions, is that just what the literature says got to that point? Or is that just more of a cost thing?
Well, certainly, I think 30 is the minimum. So if somebody's made no improvement by 30, then I'll and I would like to get them out by 50 if I'm comfortable, but if they're looking fixed by 40, and occasionally we get people who are younger and fitter and do really well, and they can be sent away, after an improvement session.
And the Medicare debates, how many sessions do they give you? Or is that just how
they don't? And some of the private health funds say they made up a rule, Australian Unity for instance, that you can only have 20 per year. Where did that come from? Right. I had an argument with them the other day, and I said, well, there's no point in giving them 20 because it's not even available. Why not give them they said, no, you can't do that. You can ask for 20, you can ask for another 10, and they usually approve it. That's sort of the game that we play.
It's a pass now.
No, he's all right. Yeah, it's fine.
If you don't have a podiatrist in the clinic, who's responsible for doing that for you?
Well, we hope that you guys have given them a lovely boot or something like that, and we're not bad at following templates when it comes to the belt, and we have podiatrists visit us and teach our nurses how to do the basic stuff, so you know, we can do things and spot edges.
concentration.
Not necessarily. I mean, some of the
I'm not getting the
private
right
systems will have their own
I should be able to get.
podiatrists and
There shouldn't be two things. The other kids coming.
things. So, but certainly for a lot of the public patients, the trouble's cost. You know, I've had at least 2 or 3 patients that I've
We're
shown
not getting
toe
it's
brace.
coming up as well.
One chap, in fact, at Berwick
That's why I was trying to.
early this year, he wanted to keep working, and I said, unless you buy this brace, I'm not even going to give you hyperbaric because it's been going on for 2 or 3 years, and you're not properly operating. It's not going to work. So get the brace or don't do it. So
Okay.
Oh, and that's exciting.
That's good.
That
That's
has
coming up. And done. And it might be to that too.
it's funny, isn't it?
And if you go in
But
the
if you sometimes
She thought you already done it.
who's had
You keep
leg
the shit,
ulcers for
and then you could
30
get
years,
It has to be.
we want to open the
maybe it's just later to spend $357 on these
Good.
fancy Circade,
So we have to go to here.
Velcro, wetsuit material type compression because every single thing you put on her main body leg falls down. And this actually doesn't.
Okay.
So sometimes, you know, when you put it together,
Well, we've got that, they're getting that.
suddenly
That's actually good because we can see what we're getting. Yeah. Good.
We have liftoff.
Yes, it's working. Let's go and play around outside.
It's working. Okay. Rain, rain, rain. Everybody knows rain.
No, they don't.
Rain is a podiatrist. It was well known to all of us, or many of us, but she has travelled down the research path over recent years, completing her PhD and pursuing postdoctoral research interests in the prevention of foot problems in people with diabetes, accelerating healing of older people with wounds, physiology of healing, community-based, patient-centred interprofessional wound care, and translating evidence into practice. She currently leads the Centre for Wound Management Research at the RDNS Institute.
Thank you. So I was asked today to talk about how to critically review a research article. So I'm hoping I'm not teaching you all to suck eggs. So just tell me move on if it's something that you already know. And so I thought to cover, I thought to start off and lead into evidence-based practice and the principles of that, and then go into the critical appraisal of research studies, clinical practice guidelines and websites, because given now that we're getting a lot more information online, it's kind of interesting how everyone is quite happy to take what's online as fact, and so it's, you know, there's a few little things that we need to think about that we can actually guide our patients for one, but also other people that we work with, and some resources that we can use. And so I guess the first thing that I want to ask is, what do you think evidence-based practice is? There's 3 components to evidence-based practice. So can people just sing out 3 components? There's an easy one first off. Yes! Yes! Oh, that's exciting. Oh my God. So that's 1, great. 2. The research trials? Yep, perfect. And there's a 3rd one. Sorry. Yeah.
No.
No?
Only got me joined so far, but
We can hear you, Steve. So the third one is actually patients' experiences. So it's integrating your clinical expertise with the best available external clinical evidence from systematic research and the compassionate use of individual patients' predicaments, rights, and preferences in making decisions about their care. And not one of these things is more important for the other, but it's kind of interesting because so many people latch on to evidence-based practice as being the research. And it's actually those three things that we have to combine in order to allow us to make our informed decisions. So it's not, yeah, there you go. So why evidence-based practice? And so I just kind of thought to just cover over this because healthcare knowledge, we know it's growing so rapidly and we'll be out of date by the time you memorise the textbook. And the new evidence is so vast, we're getting thousands of research articles being published every week and you simply can't keep up. And so we get information just in time rather than just in case. So evidence-based practice is supposed to allow you to individualise the information for the patients that you see in their situation. And it teaches you to integrate the best available evidence with the expertise, your expertise that you've built up with the blood, sweat and tears over the years, your patients' values, plus your healthcare environment within which you are working, which often limits what you can do, given the resources that you have. And it helps you challenge the dogma and avoids uncritical acceptance of usual practice. And that's where we're desperately trying to advance what we're doing to incorporate the evidence. It could be simple and quick and give you skills for lifelong learning. So it's ultimately to get the best, most appropriate and effective care to your patients so that best outcomes can be achieved. And for diabetes foot-related complications, it's speedy healing, pain reduction, because a lot of people that we do see do get pain, and improved quality of life, and it is dependent on your patient's priorities. So we'll focus, rather than looking at this thing as a whole, on research studies. And so we know this is like a research 101. There are a number of different types of research, which you'd all be aware of. There's that quantitative types, which are experimental, where you do actually put in an intervention, and that's where your traditional randomised controlled trials come in. Then there's all these observational studies, and that's where they kind of get a whole population group and they collect data on this group and they just monitor them over time to see what happens with them. They don't actually intervene, and there's a number of different ways that you can look at those. And then there's descriptive research, and they're things like surveys, and then broadening out is the qualitative research. And it's really interesting because the quantitative research can give you the numbers as to how many people do what, but they don't give you the why. They don't give you the really in-depth information about what happens with these people and why. And qualitative research is gaining a lot more strength in the general research field in being able to provide that extra depth of information that other studies can't. And I've got some websites that provide further information if you want a little bit more. Now, one of the things that you have to be aware of is that not all studies are created equal. And within each of those different types of studies, there are differences in quality. And just because it's published doesn't mean it's good, because that's the scary thing. Each study can be graded to ensure that what's included to make decisions is the best quality possible. And so NHMRC, so that's our National Health and Medical Research Council, and that's what guides and governs us in terms of our research to make sure that it is as quality as it possibly can be. And we all know that level 1 is the systematic review of all the randomised controlled trials, and that's what they classify as the top of the pyramid and the most that's what you would ideally want every bit of information that we could get our hands on to guide our practice to actually be. Unfortunately, that's not readily available for many instances. An RCT is the next step down, and that tests accuracy, and you ideally want an independent, blinded comparison with a valid reference, blah, blah, blah. Often you get quasi-experimental or various permutations of trials, but that's the best. Pseudo-randomised, for example, so it's an independent blinded comparison, there's a valid reference, but there's non-consecutive persons with a defined clinical presentation. So it's a little bit below the one above. And then grade 3, this is where a comparative study with concurrent controlled. So you can see that each time you go down, there's something that's less rigorous about those trials. And I'll just go through. And then case 4, level 4 is the case series. And so, you know, no, actually it doesn't provide. And there's actually lower below that. So you've got just a case study is obviously just one step below that. And then you've got expert opinion, which is a step below that. And that's because there's nothing out there in terms of the evidence. And you just get people who have worked a long time in that field, who have very good judgment and understanding of what evidence there is. And their opinion is then used to guide and make decisions and provide evidence. So you can, you know, when you think about it, that's obviously not going to be as high as a systematic review, but it is a form of evidence that you just need to be mindful is used. And so I popped this in because they have a body of evidence matrix based on what level of evidence was actually used. And so they use an A, B, C, D grading. And what that shows is if it's graded as an A and you actually review something and it has a lot of articles that have several level 1 or 2 studies with low risk of bias. And there's all these different things that guide you into identifying which studies or which articles you're looking at would be a level A, a level B, a level C, or a level D level of evidence. And it's important to understand what that means when you look at these articles, because the classic examples, a clinical guideline, they use this grading system for the studies it bases its recommendations on. And this is the Baker Institute and International Diabetes Institute for the National Evidence-Based Guidelines on Prevention, Identification and Management of Foot Complications in Australia. And you can see here that, the assessing all people with diabetes and stratifying their risk of developing a foot complication, that was classified as a grade C piece of evidence. And that's because the evidence base was satisfactory. There were level 3 studies, so they weren't RCTs. They didn't have any RCTs upon which they could base this decision on. There was some inconsistency reflecting uncertainty about the question. The moderate clinical impact, the generalisability, the population study differ to the target population, but it's clinically sensible to apply this. And applicability, it's probably applicable to the Australian setting. So that's what but we use this in our guideline and say this is what we need to do. And yet when you look at it and it's grade C and you look at that potential flaws, you see, ooh, you know, there's a little bit of work needs to be done in terms of confirming that this is the most appropriate thing that we need to do. But as it stands now, this is what we've got, and so this is what we use. I'd rather use this than use nothing. Then the other one that really interested me was any suitably trained healthcare professional may perform the risk assessment. And it's expert opinion, because they don't have any evidence upon which they can base that on. And this is in a clinical practice guideline. It's supported by the National Health and Medical Research Council, and they've got expert opinion as something upon which they say this is a point within our guideline that we recommend that you follow. So it's just being mindful of how they base the decisions and what level of evidence is used in order to actually make those statements. Now, as I said, not all evidence is equal, even at the same level within those gradings, and basic critical appraisal skills can be applied to a research paper in a few minutes. And more advanced critical appraisal skills can be used for journal club presentations or evidence-based reviews, and there's a number of things online that you can actually join for journal clubs, and I tell you, they make you sweat. Because it's hard work, and they really make you look at what those articles are saying, what the evidence implies, really making you go through and ensure that you've identified where the flaws are, what's really good, what's not so good, where there could be improvements, and what you would do with this paper, and would you base your clinical judgment or clinical decision making on this. And generally speaking, making a clinical decision based on one paper, not ideal. So, as I said, going back to the level of evidence, you really want to have a number of different studies that have actually done work in the area to confirm that what's actually been identified actually is the case. And that's why they really push for having systematic reviews upon which you can base your evidence. But if it's not there, you've got to base it on something. And you know that patient sitting there in front of you and what needs to be treated. So you need to actually do what you can do. And so the aim of critical appraisal is to understand the strengths, weaknesses and potential for bias in the clinical research before you apply it to the patient. And so the common themes is that you really need to look at validity, applicability and clinical importance. And the validity is the extent to which the studies are likely to be true and free of bias. And so, for example, with internal validity, that just means, does the study minimise the risk of bias? Have they compared two different groups and randomly allocated them in those groups rather than chose some to go in one group as opposed to another in some weird and wacky method, which would have made the results less likely to be, or more likely to be as a result of chance as opposed to or as a result of the way that you've chosen those patients, my apologies, not chance. And externally, validity is, can the results be applied to patient populations which weren't included? Have you excluded so many things and factors that we normally see in our patient population so that these results simply can't apply to them? And that's what fascinates me with a lot of studies that, you know, they do on people with hypertension or diabetes. They exclude, you know, all the comorbidities that are associated with that clinical problem. So for diabetes, for example, they often have people that don't have that have good blood pressure, that have good cholesterol levels, that have, you know, no other real comorbidities, and that's not normal. You know, in our world, these patients have multiple comorbidities, so we actually need to make sure that the studies that we look at have similar populations so that we can be much more likely to apply that and it will be relevant. Applicability, so how the results from the clinical trial apply to a specific individual or setting. And that's a thing, the different settings that we work in, so the regional areas as opposed to the metropolitan areas, a tropical climate as opposed to a non-tropical climate. Because I remember talking with people from Queensland, and putting a total contact cast on someone up there is hard. It's so hot and they just can't tolerate it. You know, and wearing shoes, like you know, it's flip-flops or sandals because it's just so hot. And to get them to wear anything else, it's really hard. Or India, where they actually fashion these clogs out of wood, and you know, there's all sorts of stuff going out, and they don't have the resources. So it's just thinking about what your environment is, looking at what the research papers actually describe within their environment, and seeing whether there's some way to actually apply it.
I'll let up to everybody.
So this is our first try of this. To decide whether you can apply that evidence to your patient, you really have to consider that individual's characteristics, their preferences, their values, the environment within which you practice, and then your expertise and familiarity with an intervention. Because that's the other thing. It might sound great on paper, and then you have to try and figure out how the hell to actually do it, you know, on that patient. So if it's another way of, you know, debriding, another way of putting a dressing on, another way of putting padding on, you have to somehow figure out how to do that in that clinical setting. And it might not be so easy as you think, and you might actually need some resources, some mentoring, some support, other things that might be able to help you to do that. Or you just don't have the resources, and some things you just can't do because you don't have this experience yourself, or you don't actually have the equipment, you don't have the time to be able to do it, and a number of other things. So before extrapolating beyond the trial, ask yourself these questions. Are the results clinically important? Because often you see these studies and they show statistically significant results, and it's really, that's great on paper. It sounds like there's a real difference, but it's actually 2 people, you know, have actually improved, you know, after 12 weeks of care, and in the clinical real world that means very little. But if you're talking about 50% of people improved in 2 weeks, you know, that's meaning. And so it's just really making sure that that information is practical and does have a clinical, can translate clinically. Do the results apply to my patients? What are your patients' values and preferences? Can this practice be implemented in this healthcare setting? And how can I help my patient make the decision to actually engage and want to take on this treatment? Because it is their body, and they're ultimately the ones that have to be comfortable to accept or to take part in this. So it's all of those things together. So you need to consider the point of view of your patient, and if you don't consider their viewpoint, it might compromise the treatment as well as the relationships, because there's a lot of, and as you know, so many people say non-compliant or non-adherent, and really a lot of that's about not actually explaining well enough for that person to understand what it is that's needed and whether they actually do want to engage in that treatment protocol and whether they were involved in that management plan in the first place. So there are a number of tools available to evaluate research articles, and one of my favourites called the CRAP tool. It's a critical review of abstract presentations, and I do like that name. So has anyone heard of that? Yeah, because you've Monash, you guys did Monash, yeah? So this one, I actually worked with one of the writers of this, and they did a 10-item checklist, and they talk about it to quickly review an abstract. And really you can actually use it for an article. And so it actually suggests that you go through 10 questions, and they're really really simple when you think about them, but they also look at the different types of research, because some of them you wouldn't expect some of these things to actually be relevant. So you just need to make sure that you look at the article and what it is, that the type of research that's been done, and seeing whether it is appropriate for that. And really this kind of guides you to make sure that what you're reading makes sense, it has sufficient rigour to actually produce the results that make a difference, and that there aren't flaws, because things do pass through and get published with significant flaws. You know, I review articles, and you know, if you've got 50 million things on the go, and you know, I'm pretty anal when it comes to these things, but even so, you can't catch everything. So you know. So does the title reflect the objectives? Does the background information provide good rationale for doing the study and lead to the purpose? Are the objectives of the study clearly stated? Are the methods clear and complete? Half the time you don't know what that patient population is. They don't describe them well enough. Half the time they don't describe the environment within which they're doing. Half the time they don't describe the actual methods of the treatment that they do. Half the time they don't, you know, there's all these things that, you know, you read these things, and often it's because there's only a small amount of space that you're given to write an article. And so, you know, these poor authors, it's just, you know, they're stuck between a rock and a hard place where they have to convey all this information in a small amount of space. So my heart goes out to them. However, you do have to provide sufficient information upon which a reader can be satisfied that what's actually done is sufficiently rigorous, that the outcomes actually make sense, are appropriate, and you can then apply in your clinical setting. And some of those things you do need to look at is the randomisation of subjects, sample size, because if you don't have enough participants or you have too much, they're both problems. Because if you don't have enough participants, the likelihood of you actually having results that are statistically significant are pretty low. But if you have too much, what might happen is the results, you might get something statistically significant by the virtue of having so many bloody people over that long period of time, but you know, it's not clinically relevant, you know, because took 10,000 people to show like 2% difference between the two population groups, you know. So it's really kind of you've really got to understand what's done and the methods that are used. And you've got to understand the dropouts. What happened for those that withdrew? Why did they withdraw? And, you know, did they report, did they factor that in their statistical analysis? Because there's an intention to treat component. So what you're supposed to do is you're supposed to factor in those people as though they were still being treated even though they withdrew. So there's all these things to make sure that the results are rigorous. And then, is the intervention appropriate to produce the desired effects? Is it clearly explained with sufficient detail to be reproducible? So reading that, would you be able to apply that treatment in your clinical setting? And in a lot of cases, there's not enough information for you to be able to do that, which is a real pain. So do the results correspond, the other thing was clinically feasible, and that's the other thing. I often see studies and you think there's no way that you would be able to do that in a clinical setting. You don't have the time, you don't have the money, it would probably kill the patient because it hurts, or, you know, like, and because the people that do a lot of this research, many might not be clinicians and don't work in those clinical settings. They have these great ideas, but they don't actually understand the reality of the real world, you know, the clinical environment. So, and do the results correspond with the study objectives and other details specified? Are the conclusions appropriate given the study limitations? No study is going to be perfect. And so this is where you just got to make sure that they outline where the deficits might lie, and does that make sense? You know, is it sufficiently described, and can they be overcome with the rest of what they've done? Can they generalise those results appropriately to patient populations and clinical situations? Are the outcomes stated? And has the conflict of interest and or study sponsorship been disclosed? See, this is the bit, you know, it's kind of fascinating because a lot of companies pay big bucks to actually do a lot of this research, and so what they're now having to do is actually provide untied funds, which means they give you the money and you can do what you want. You can do, not what you want with it, but you can. You then have the freedom to actually undertake the protocol and undertake what needs to be done without interference from that company, and you can publish it even if the results are negative, because so many results of research that is negative isn't published, and they've actually shown and done meta-analyses to show that most journal articles prefer to publish positive results. So a lot of people who submit articles where they didn't find a positive result would get knocked back, and so that's a problem. Yeah, because then all of a sudden you get all these only publish those ones where, and there's been companies where they've had 20 trials, 2 were successful. Guess what they published? Yeah, and so that it's a real problem. So this is where you really have to think about these things. So there are other tools available. So I've just got this, and so this is will be available for on the website. Yeah, this is available. Yes. And in clinical practice guidelines, everyone, I mean, I must admit, I agree, I thought this as well, where clinical practice guidelines, you just assume that they should be of sufficient rigor and they've gone through these whole processes and they should be great, you know, you should be able to trust them. Well, unfortunately, there are clinical practice guidelines and there are clinical practice guidelines. And so they've developed an appraisal guidelines research and evaluation tool, the AGREE tool, and that was developed to assess the quality of the reporting, the quality of some of the aspects of the recommendations, and the likelihood that it will achieve its intended outcome. So, for example, for the diabetes-related foot complication guidelines, much is based on expert opinion because research evidence isn't available. But you know, there are I came across 3 different guidelines: the International Working Group on the Diabetic Foot Guidelines, and they included all those involved in the research of the area from around the world. And so, expert opinion from this group, that would mean something, yeah. But then I was working in Canada for a while, and the Registered Nurses Association of Ontario guidelines, they included local Canadian experts with no reference to international guidelines. That scared the bejesus out of me, because they had expert opinion without reference to the true experts. And so, you know, what would expert opinion in that environment, how much credence would one be able to put there? And then the National Health and Medical Research Guidelines from Australia, they used local experts and the International Working Group of the Diabetic Foot and other international guidelines and related them to the Australian setting. So then you think, you know what, these guys, you know, expert opinion with this guideline, I would have some trust in. But you've got to keep in mind that just because the research has been published or it says it's a clinical guideline, it doesn't mean it's of high quality. And as I said before, meta-analyses and systematic reviews are the safest bet. So things like the Cochrane systematic reviews are things that you would have trust in, because they go through a rigorous process before they're able to be published. And clinical practice guidelines should be of good quality, but it is worthwhile to check. So there are other critical appraisal tools, and there's sheets to assess systematic reviews and single studies. So there's a whole heap of stuff out there that you can access that can help you. And critiquing weak pages. So this is really, you know, you follow the fundamental criteria to judge any source of information. So things like, you know, the author, the date of publication, edition or revision, basic information that should be there. And they require a second level of scrutiny though, because you don't know who's behind what's being put there. And it could be companies, it could be just an individual, it could be some nutter out there, who knows? What can the URL tell you? Who wrote the page? Is he, she, or the authoring institution a qualified authority? Is it dated? Is it current? Is it timely? Is the information cited authentic? Does the page have overall integrity and reliability as a source? Is there bias? Could the page or site be ironic, like a satire of a spoof? Like, you just don't know. You just don't know. And that's the thing. Anybody can put anything on the web. Anybody. And a lot of these IT people have a lot of time on their hands. They don't have a social life. So it's like, you know, so it's just, you've got to kind of, you know, take a step back and have a look and just do some little checks and make sure that what you do, that what you look at, you do think a little bit about. And there's a little bit of information about where you can go to get more information. And there are a number of resources available on articles, the clinical practice guidelines and reviews. They've got a great handbook from Cochrane and the Cochrane Library, and then there's clinical evidence. The British Medical Journal is a really good review. If any of you guys want to do great case studies and things like that, they've got really great guidelines as to how to produce a really good, high quality paper for case studies. Then there's Australian clinical guidelines, and then evidence-based research resources. Again, British Medical Journal, which is I have a lot of time for, and then clinical utility. So I stumbled, you know, UK, you stumble across things. Columbia University has great stuff, and then Evidence-Based Practice Centres International, and then a list of multiple resources. So the web is a really great resource. It has a lot of information out there. You do have to kind of scrutinise what that information is, but overall it makes things a lot easier. And those of you who do the Monash course, it's even better because you know all this stuff and I've just told you to suck eggs. So good luck. I've probably made you all think all negative things about articles. Most articles are great, but just, you know, have a little bit of a look, use some of these tools that might help you get a better understanding of what they do and whether you can use that information in your clinical settings, and just question. That's all this is about, just question. I've zoomed through that. Oh, no, I haven't zoomed through that very well. Thank you.
Thank you very, very much. Questions for Raina? I wanted to say the presentation.
Yeah, we can have a look at the close of that. It's not a presentation still up.
Maybe. Oh, no.
Hi, Raina.
Oh, I've got mine. Thanks for you.
Thank you very much. Can we save Martin's presentation on Raina's computer? Is that hers? Yours?
Yeah, that's mine.
We can put it on a hard drive. It's probably the hard drive to plug in. Yeah, that's
Is
probably.
that all right?
That's
And then
probably
can you upload it in Dropbox? Or,
Yes.
Okay.
I won't do all that now.
So I'm so excited because it worked.
In the end, now it's back to me on the screen.
Is mine still open?
No, the basement's closed.
Can we just
Yours.
reopen it, maybe?
It?
It's not a PDF, is it?
No.
But maybe compress. Can you?
Well, I can just save it onto. Yours is called Apollo, Raina? Yours is called Apollo?
Mine is called Apollo.
I'll put in presentations.
Do you want to put, I don't know, go to, oh yeah.
And
I'll save it in there.
HBO.
Yes. Like that. Then eject which one?
Not just the shotgun. Sorry, I shouldn't.
I don't know which one.
Hi, thank you. So it's called diabetic foot and we put HBO.
I think in future we probably have to get it instead of sending out a link. For instance, like we did today, send the link out when the link starts.
Yeah.
Because that seemed to work much better.
Okay.
Sorry. That's part of the problem.
Oh, so you
Now we need to go back into.
So we've got
she's
It's
over
actually a really nice time of year.
You guys know? So, was that international?
Extended correspondent membership.
Just Dr. T. She wants to go.
That's so strange. I went to Germany last year. Just got some more trainings and stuff.
And then they go back, they don't get home till 3. So they have to go and see someone else. Then it's not No, we don't mind, or, for important ones, but sometimes it's we try to persuade them to different time and stuff.
We'll get that if they will be
No, you can just access. So we're just running through the AGM for those who are still hanging about.
We've got all the attendees.
Yes, we make the attendees. President's report, and we'll send it out tomorrow as well.
Nominations for committee positions.
Okay.
In terms of number of presidents, it doesn't matter.
We don't have a quorum, and it was something for our constitution at the time, because when we first set up there were 6 people. There were only 6 members when we first started. So we knew we'd never get 50% of members here, so we set a quorum, I think, of 5, something like that, with a really low quorum number. So yeah, and if we don't get them, those who are there can vote to accept the number who are there or something. It's quite, yeah. Okay.
Nominations?
Do nominations first, or we do that next?
Where are we up to?
I don't know.
Yes, minutes.
No, no.
Minutes, 2013 AGM. Somewhere. Which was how long?
We think
it was a very brief meeting. It was about 10 minutes. Just the
Yeah,
main.
President's report. We have yes. Yes. Yep. Yeah, there was a big, at the end of the last meeting, there was a big turnover of the committee, so stuff I think got lost in the handover. Yeah, and they will be sent out. Okay. Nominations, 1, 2, 3, 4, 5. Yes. Right. There. That's Raina's there. Yes, yes. So 1, 2, 3, 4, 5, 6. So we've had 6 nominations for. We do as well, but that hasn't been uploaded into here. Is it? Ah, okay.
Hers was definitely in it.
Fine. I will trust you. At 7, so there was 1 vacancy because Matthew didn't send his in. Despite him saying he did, but even if he did, he hasn't paid his membership money yet, so he wouldn't be eligible. Yeah, but he hasn't paid his money, so therefore he would not be eligible anyway. So
His intention.
is to pay his $100 and fill the casual vacancy.
So there's no over. There's no.
We are one person short of our full committee of 8, so it's our maximum committee. So therefore we don't need to have an election. And at that committee meeting, the first committee meeting, the committee can appoint any member who is interested to the casual vacancy.
I'm interested in
Yeah.
Oh, absolutely.
I don't know if you got my email, but I sent you my email with all my details for membership, and I emailed Stephen.
Is that the one I forwarded to you?
Is your name?
Your name is? Oh yes, you did. Yes. So
Yeah, and I said, did you get
and you're from Western Australia and just over here on
I
the.
came to the W's conference.
Yes.
And
Okay.
they
Yes.
interviewed and I-
Yes. Fine. Welcome and yeah. And,
Yeah.
right. Yes.
I did, and I said to my membership.
Yes.
Because when I do it online.
My pen dry.
Sorry, I've just got.
So I
Yes,
forwarded
okay,
it.
keep it there.
Okay.
Sorry. Thank you very much. Sorry, I was too busy with technology.
Did it work?
In the end, but I had to
It's not
redo
bad,
it, so I had to
but
start
I
again. So I think
so
the
would have been like
I set up a
last
week ago, and I
week,
think the link expired. And that's what
nominate
I did it. Once we got in here, then I did it again. It worked. That's good. And we can have up to 10 members anyway on our committee. So we at our next meeting we'll So it's really good to have people who are interested in that perspective.
Thank you very much.
Anytime. See you later.
This is our finance report that we're up to. I jumped ahead. Sorry. We've done that.
The treasury report should have come after the.
I thought so, but we jumped. That's so for the year, our income was $8,670 because we didn't run any major seminars or anything. So just brought in a bit of money. We spent $13,000, so the loss of $4,400. Most of that went to the web hosting for the Fran Game seminar, which cost us $5,000. Hence we're looking at cheaper alternatives, which
She was worth it.
oh.
That was
It was a very good seminar. We got her for free type of thing. She was wonderful, engaging. But the cost of getting all the web hosting done was quite expensive for us. But we use that as an advertising thing as well, because we sent it to all of the podiatry associations, inviting all of their members to view it. So we use it almost as a bit of a membership drive. Hard to know if that worked or not. But in future, if this does seem to work, and people will be able to go back and view the YouTube link, so I'll send that out to all members, and everybody will be able to view at least Raina's part, because the first bit we didn't get working, through YouTube, and that will be positive,
We
I
also
think.
upload the PPTs that
Yep.
PowerPoint themselves on in the next area, so that you will
So, yep.
Can I ask in relation to this report and previous, what are the membership numbers looking like for this year? Are they sort of on track?
Our membership, our current, it drops always at the end of the year, then people sort of renew slowly, and then we get new members, and so
It's about the same.
it's around, like we ended up with 53, I think, at the end of last year. We're about 38 at the moment, which is probably about where we'd expect, because some people will, and part of our problem has not been engaging with people who don't live in Melbourne.
Yeah.
And that's, because all the workforces in Melbourne who are driving the professional association, it's hard for us to run a seminar in Western Australia that's cost effective, but having a West Australian member, yeah, but again, but having two people there means it's not all on one person. You can then use some of the, like Raina's talk, you could reproduce there. Again, with this web hosting, you could almost get people together in a room rather than everybody thinking
We've
that.
got a special interest Irish group.
Yeah.
Works for WA.
Yes.
And there's about 9 or 10 of
Yeah.
us on that group. So,
And this gives a bit.
There's a lot of potential
Yeah.
for more collaboration.
And it then lets, like, you could run this seminar in another place, so you're all together. So again, you've got the opportunity to have the discussion rather than everybody sitting by themselves.
Even like the Skype thing,
Yeah.
whatever going on there,
Yeah.
like that would work if we could just set
Yeah.
it up. And that's
Yep.
right.
Yeah. So
Yeah.
well, I mean, that's why I was running in and out, because one of our ex-committee members was sending texts saying, can't get on. So I go, okay, then we went through, yes, I can get on now. So, yeah, and she could hear what we're saying, because she said, oh, I better find those minutes for you. So, our membership numbers are staying about the same. Our, our general expenses are matching our general income. We had a fair bit of meeting costs because we had one meeting with all the interstate people together in Melbourne, so we, of course, covered their airfares. But that was worthwhile, I think, getting people face to face, so that then when you talk to people on the phone, etc., it's a bit easier. And again, we might end up using Google Plus if it works appropriately. So we've got just under $70,000 in the bank, which I mean is enough for us to play around with, and it gives us a buffer. So if we wanted to run a conference, we've got enough money there to underwrite anything. If we wanted to fly international speakers, etc., we can underwrite the conference. Where the first couple of conferences were underwritten by hospitals and podiatry departments, who we sort of use their generosity and things. Yes. So, but now I think we're a bit more self-sustaining. Mm-hmm.
So we will also have Queensland Grant that's in the process of changing over as well. And I spoke to Jason, and he's very enthusiastic from just the few brief words we've had in getting more Queensland. It's such a weird, sorry. Yes, I was going to say, Queensland's good. Matthew's just been like, they had a baby, so he's got a baby brain. Everybody else we've got, so that's good. All right, business with notice. Was there any other business to raise? No. Any business without it?
Oh, we need to thank you guys for topics. What do you want to know about? Is there any topics that you're interested in?
Well, one of the suggestions was actually that we follow what the College of Surgeons are doing in terms of legal grow insurance. So we put a program together and we take it around Australia, from state to state to state. That's what they do. They put a program together and they take this thing on the road. So they have like sessions in every state, or workshops and lectures and whatever, however you want it to be. So that was my many topics.
The other thing I suppose is to advertise that members getting a discounted rate for both the Liverpool Diabetes Conference in April next year. I just sent out registration brochures, etc. for that, and the diabetic, what is it? The lower. No, the lower limb deficit.
Lower limb problems in diabetes are Asia Pacific. That's in
November. And again, we get discount membership for that. So, if you went to one of them, you get your registration money back. So.
Yeah. So that's the whole thing about collaborating.
Yeah.
If you read my president's report, it's all there. That's what I basically wrote about.
Yes.
Stop it. So please, if you guys think of things that you actually want more information on,
and talk to your colleagues and find out what.
Because we'd rather give you stuff that you want, and so we'll make stuff up. We're happy to make stuff up, but it's just we'd rather give stuff that people would be genuinely interested in, that don't get in other forums, that we want something that's specific to them that they've identified as an issue in their clinical practice.
One of the common things that I tend to get asked is around how do you get the relationships happening with, you say, I've got the vascular surgeon and I've got the blah, 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 but I just can't get them all to talk and work together, and given how much you're doing in terms of trying to get people on board, whether that would be a useful topic just around generally building a team and
Doctors hate each other.
So don't talk. Just a team. Like, how do you build that team? How do you engage?
We only have one consultant. One consultant, two at the max. We have vascular and endo, so one surgical, one medical. Yeah, you don't want to have two surgical consultants.
I get all the concepts. I'm just saying, as a general gist out there, what I do here is an podiatrist working out in God knows where, and is trying to get the GP to prescribe the antibiotics. They know the antibiotics, they're just not endorsed yet or whatever. And how do they get them on side? So it's more about onboarding other healthcare professionals.
I don't know that that's something you actually tell people how to do, because everyone's different. Like, it's the personalities that you deal with.
Well, not really, because it's about presenting your information in a way that actually would convey to that other provider that they need to be involved in that person's care, and not everybody can do that.
I think in general correspondence, which I think just as a general rule, like it's something along the lines of communication with health professionals and what's appropriate versus what's not.
I can just tell you, it's a general problem across all public hospitals communicating with GPs. GPs are into their 6-minute medicine, and they're into referring on. When we get how many 7,000 to 8,000 referrals a month for at the Royal Children's, so all discipline. And most of them are things that the GPs should be able to manage, but it's easier to send them off. So it's really hard to engage with GPs for...
I mean, for podiatrists.
But I'm saying even at a hospital level, if a hospital like the Royal Children's is having difficulty engaging with GPs...
Well, I know what you're talking about. So you want clinical... So there's people that have expertise in communication, that work in health, that, you know, and how... I mean, we could do something on how to improve the way that you communicate with other healthcare providers to improve the patient health outcomes. Is that what
It's not
Yes.
your brand. You're not going to fix the GP. It's about, as a podiatrist, I'm not a hairdresser of the feet.
Yeah.
Essentially.
How to improve the way you can communicate.
It's relevant.
And part of that problem is there are a lot of their relationship with podiatrists are hairdressers of the feet.
Well, let's not go there.
I know.
This is
But,
It's a conversation for
yes,
another
I know.
day.
Yeah. But okay, sorry.
To improve the patient health outcomes. That's
Yep.
a good one.
It is relevant. But even if it's not a lecture, maybe like a forum.
Yeah.
People we can ask questions and people can give their opinion.
And you could bring in a GP liaison person, because most hospitals, again, have the GP liaisons, and bring in somebody from Medicare Local if they survive.
Or someone from the next iteration.
Yeah, and they can tell you how they communicate with their GP groups.
And then also then someone who is used to doing it as a podiatrist. Because I know I've never had problems.
Oh, okay.
I know, because I don't,
And some of it is about your confidence.
Yeah, and I just, because I expect them to be engaged. Yeah, and if they don't, then that's their problem, and I will make my problem their problem.
Part of that document is actually picking up the phone and saying, can I speak to the GP? Are they on today? Can I speak to the GP about this patient, please?
Yeah,
And a lot of people
I always
do
get
that.
through. I always got through.
A lot of people do that.
Another topic I found interesting a number of years ago was the can boot fitting. I found that was really fantastic, but I've kind of forgotten some of the key pointers. What about that?
I'm not a member, but I think having a specialist in is always good, like a surgeon or a vascular. It's just always nice to see what they're doing and saying and thinking, and not just on the letter or phone.
It might be good to hear from some of the new hires for clinics that have popped up, speaking from country Victoria, the different challenges they face. That would be applicable to our colleagues in Valentine's, yeah.
I'm actually just reading here about this establishment of competencies and the new structure of the budget. I'm interested to know about that, to see what's the plan for podiatry into the future is. No, it's a long way away.
It's early days where we really, it's kind of like education program in the States. It's a long time in the planning. We never really know it to pay it off. But at the moment, there is.
Yeah, but it could still be, but you know what we could, I reckon, get someone from pharmacy, they have specialist advanced practice, and maybe we look at what they've done in their profession, what the OTs have done, those guys are lips and fans and
That's what might happen.
and then we can talk, and we can talk about the Tripod UK people, and maybe get someone Skyping. Maybe we can get one of them to talk through this, you know?
The possibilities are endless.
I'm going to the International Shark Forum this year in Germany last night. I'm happy to talk about that.
Fantastic.
So that's Shark.
No, that's actually that's not going to be honest.
Jill just sent a message through saying, I'd like to congratulate the committee on the fantastic work they have done in expanding the reach of the group in the past year.
Thank you, Jill. Thank you, Jill. I can't talk properly. She can hear you.
Yeah. She just can't talk.
Hi, Jill.
Okay, so that's any other ideas? So cool, look, we've already got, you know, for the next. So what's, seeing something in practice that you thought, oh, I need to know a little bit more about that. All right, please.
Yeah, and I'll have a chat with the WA group and see if there's anything, I would say no.
Even clinical assessments, even, you know, you've seen other professions do stuff.
I was thinking about, we've been like tissue samples, biopsies, so we just have to give someone's not today and didn't really know what to do with it. Do we take it?
So practical, practical pathology.
Histology, actually.
Yeah, not so much swabs, it's more tissue, it was high granulation tissue that we weren't sure whether it was.
Doing biopsies.
Do swabs as well.
Yeah.
The how, what, where.
How's the ADS conference going?
Yeah, it's okay. Not a lot of foot stuff. I'm chairing the foot session tomorrow for the posters section.
Oh, okay.
I think it's only about 4 posters. There were like 7 and then they lost 3 or something. Something happened and so now there's less, but I haven't seen a lot for the ADS. But that's okay because I think it's mostly a lot of GPs, a lot of clinical practice, endos, a lot of drug stuff. So
anything else?
Okay. All right.
Sorry, hang on, Mama.
Just going into how you can sort of continue working your own, just get stuff in your own way. And I don't think you can do it as a lecture series, but if you break up into groups and have someone to facilitate again just a discussion, this is the way I learned this to BJ or anapodic modification.
Okay. Practical, different techniques.
And this was also supposed to be a conference here.
Yes, but because of the Asian Pacific Conference and the Liverpool Conference, we figured we would put our support into supporting them rather than supporting our own, because we'd be doubling up, we'd be conference overload, and we'd be going away from similar conferences which are working and they're supporting our members, even though it's not giving money from them.
I go merge with those groups. Because no one's doing one of them more than the one.
The one that Jeff Sussman, the Asia Pacific one, is not a podiatry specific group. This is a podiatry specific group, and that makes it difficult to merge. But we want to have robust associations, so we try to develop.
And the Liverpool one, well, it's Matthew Haley, really, and so we're supporting that and collaborating, but it's still the same.
But he's supporting us, and we're looking at options around trying to run a seminar for us as part of that, or before or after type of thing, like we did with Fran Game, but run it in Sydney. So pull out, maybe we'll be effort to give a 1-hour lecture or whatever to podiatry specifically, and try to work something like that. So we're working on that. All right, thank you very much.
Thank you.
And the next AGM will be next year.
Next year, and we'll have the minutes this time. But one of the things, right, so please email any ideas, anything for topics and stuff, ongoing.
Yeah.
Ongoing, just like you. Constantly.
What new stuff?
Yeah. Cool. I mean, that's stuff that's useful.
Yeah.
Yeah. I'll send some of the ideas as well.
Oh, yeah, okay. Yeah.
Thanks, Jill.
Okay. I've just finished my